Hi, this is Brandy Babin with Mana Health Partners, bringing you another educational series video, this time on wound care documentation. So, ACA and high litigation documentation encompasses several different areas: wound care, falls, I wanted to make this video specifically on wound care, so it was short, so you could refer back to it if you needed to. And then we'll do a different video for falls and for weight loss. But this one on wounds really covers pressure ulcers, surgical wounds, diabetic wounds, trauma wounds, and vascular wounds. So it's talking about how we're going to document these wounds. Why are wounds so important? Why does everyone put so much focus on wounds? Well, first of all, because of ACA and other state agencies, including JCAHO. So they want documentation to ensure that we're doing appropriate care. And then any inadequate or missing documentation ends up resulting in fines or penalties or even survey citations. So super important there. And then proper documentation demonstrates that we're adhering to evidence-based practices and care standards. We're not doing something that didn't work. We're doing something that has been verified and is now evidence-based practice to follow the wound care. So legal protection against litigation. It's a very high litigated area. So the documentation that we do serves as proof of what we have or have not done. If we've documented that we've done it, then there's less likelihood of us, if we're following evidence-based guidelines, to have a litigation against us. So if a wound deteriorates, proper records can show that appropriate care was given. So it is possible that even though you're doing everything you can and you're doing evidence-based practice, look at Superman, who ended up dying from a stage 4 pressure ulcer, who had the best care in the world and a full-time 24-hour-a-day caregiver. Christopher Reeves, when he died, he was getting everything that he could and still ended up dying from a wound. So even the best care that we can provide doesn't necessarily mean that we're going to get the best outcomes. But poor or inconsistent documentation can be used against a facility in a malpractice claim. So it also talks about continuity of care and the reduction of risk. So detailed records allow for effective communication between healthcare providers. You can go in and see the wound care physician's notes, and we can see they can see ours. The documentation includes characteristics that were often performed by the wound doctor, treatments and progress notes. So we're looking to see how big the wound is, what they've documented, the stage of the wound, etc. They're looking to see that between their visits, between them doing whatever they're doing, if they're doing debridement or they're changing the treatment up, that there's been no deterioration during the time that they did that and the next time that they come in and visit. And it's assuring that the wounds are monitored consistently. So nobody can come in and say, well, nobody's looked at that wound for a week or 2 weeks or 3 weeks. We've got documentation that not only did we look at it, but this is what it looks like. And so it's also a great defense against accusations of neglect or abuse. You've left my mother with a wound that's getting worse, and then this happened. Well, no, because we've got extensive documentation that we've done, identified the wound, treated the wound, and monitored the wound. So while the wound physician is seeing the patient every single week, we should be seeing the patient a couple of days after to make sure that whatever he did, whether it is doing a debridement or implementing a new treatment, or even just saying that the wound might look infected and he's going to assess it in the next week, that we're following up on that as well, and that we're in compliance with following up on what he's documenting on. So some documentation in the HPI. So first we're going to identify the wound. So where is the location of the wound? So we've talked about this before, in the sacrum, the heel, the left arm, wherever the wound is, we're going to mention that. And then the type of wound. Now we don't have to stage it. We're going to have the wound doctor stage it, and we don't want him to stage one thing and us to stage another. So we're going to say a pressure ulcer, a surgical wound, a diabetic ulcer, but we're going to identify the type of wound. That also allows us to use an ICD-10 code if it's a new wound. If it's a previous wound, we're going to use the same ICD-10 code that the wound physician uses. Initial discovery date, if it's a new wound, so you can document that the patient noted to have an open wound today or yesterday. And then the cause of the wound, if known. So when you get that Doppler back and they have stenosis, we can document peripheral vascular disease, or if they end up having diabetes, a diabetic wound. So it's very important that if we know the cause of the wound, or we're going to explore what the cause of the wound is, that we document. Drainage. So is there no drainage, serous drainage, sanguineous drainage, serosanguineous drainage, purulent? Is it thick, green, yellow, odorous? All of those things. Super important to document, not only on a new wound, but on a wound that we're monitoring 3 or 4 days after the wound doctor sees it. Because if he's saying it looks great and he's debrided it, and now all of a sudden we've got a lot more drainage coming from it and the drainage doesn't look good, that's us documenting that we've followed up from the physician and that we're collaborating with him and that we're monitoring that his interventions were effective or not. We're going to document about the peri wound. So is it red? Is there erythema? Is there warmth? Is it macerated? Is it calloused? Is it indurated? And then your pain assessment on a 0 to 10 scale. Don't just say the patient has pain in their sacrum. You're going to want to identify not only the level of the pain, but then the description of the pain. And the question then is it burning pain? Is it sharp pain? Is it throbbing pain? Is it aching pain? And then any interventions that we put into place. So not only do medications help with pain management, but turning in repositioning, utilizing pillows and support services, as well as changing the dressing. If you've got a dressing that's bulked up and has started to come off, and it can cause more pressure to areas that are surrounding that wound. So under assessment and plan, what are we going to document? Well, you're going to document the wound care order. So the dressing type, the cleansing agent, and the frequency. So if this is a new wound, we're going to cleanse with normal saline, and then we're going to pat dry, and then we're going to put alginate, let's say, if there's a lot of drainage, or we're going to put barrier cream if it's not open, but just really dark red, or if it's just starting to slough that first dermis and epidermis layer off. Any medications applied. So any topical antibiotics, some triple antibiotics, some nystatin powder or cream, silver, anything that we're doing medication wise, we're going to add that. Any compression therapy. So if you're talking about a vascular wound, is it arterial or is it venous? If it's venous, we should be using compression, trying to get that blood flow back. Any pressure relieving interventions, such as offloading, repositioning support services, a low air loss mattress, a wheelchair cushion, a ROHO cushion, any of that. And then nutrition, hydration considerations, so protein intake and then supplements. So that's going to be under your assessment and plan. Also, physician and provider notified. If there is a new wound or a worsening of wound, have we documented that? And we're going to document under assessment and plan that if there is a new wound, we're going to notify him. And if the wound is worsening, we're going to notify him. Or if we discover that it's worsening, we're going to notify him. Family guardian notified, changes in treatment plan, follow-up noted. So we're going to see the patient as needed, and usually it's going to be a week from today's date. because the wound doctor came 2 or 3 days before. So then he's going to see the wound and go, okay, I'm going to change it up, or he's changed it up when you called him today on your visit. And so now we're going to follow up and make sure that that change up is effective. And then any patient or caregiver education. Remember, caregiver doesn't need to be a family member. It could be a staff, whether it is the nursing staff, as far as CNAs go in offloading, turning, repositioning, or nursing staff regarding keeping the wound clean, dry, and intact. And if the dressing gets soiled, having a PRN dressing order available. So under your HPI is where you're going to document the location of the wound. You're not going to stage it. The doctor has already done that. Or if the doctor hasn't seen the wound, then you can write that the wound is open or closed, but you're not going to stage it because you stage it as stage 2. They come in 1 day later, stage it as stage 4. Then you've got a huge change in how your wound is being documented. How the dressing appears. So if the dressing is clean, dry, and intact, there's no need to remove the dressing. But if the dressing is soiled, has purulent drainage, if it's leaking out, you should be removing that dressing. You should be looking at that wound. And then you're going to be cleaning it off and seeing what the actual bed of the wound looks like. And then you're going to document how surrounding skin appears. Is it warm, erythema, macerated, no signs and symptoms of infection? If you've got a dressing and it's clean, dry, and intact, but the peri wound around that dressing is really red and inflamed, are we looking at cellulitis? Are we looking at a wound infection? I don't know, but we have to look. If issues are noted, a call to the wound care physician is pretty important because this is their patient as well, and we want to collaborate. So we would document that and we would call them, and we could take pictures and send them in a secure WhatsApp or a HIPAA compliant memo so that they can see it. You could call them and let them know. And if they said, yes, I know, I'm watching it. Well, this is what I'm seeing today. Yes, okay, we're going to either start antibiotics or we're just going to do topical antibiotics, depending. And then if a wound care provider is not following the patient, say it's a new wound, you should be writing a referral to the physician, an assessment of it in under the HPI, the plan of care, and then the treatment should include if the diabetic, blood sugar management, if they're needing protein or other RD interventions. You should be documenting repositioning, lack of wound infection or wound infection, if you're thinking that. Wounds and documentation frequency. So Medicare allows you to see a patient with a wound as frequently as medically necessary. So that could vary depending on the wound and where we are in the wound. A patient might need a wound visit every week, twice a week, and then maybe once a month after a month or two of getting it stable. But it's based on the severity and condition of the wound, but generally requires regular assessments, regular. So we should be looking at this on a regular basis, and wound care visits to be documented and justified by the patient's needs. So it could be weekly checks for heavily draining or infected wounds, or monthly for stable wounds. However, the frequency must be justified based on the wound condition documented in the medical record. So was the wound debrided? Is there high risk of infection? Is there diabetic involvement? All of those pertain to how likely the patient is to need a wound care visit. And then providers must document the wound's progress, size, drainage, and any changes at each visit to demonstrate the need for continued care. It is highly recommended that the treatment plan for a patient who requires frequent repeated debridement to be reevaluated to ensure that issues include pressure reduction, nutritional status, vascular insufficiency, an infection, all of those should be documented. They're being documented by the wound physician, but we should be documenting them as well. So the goals of treatment, they may not be the same for every patient. So the assumption is the goal for the wound is to heal, but some of them may not ever heal. So what is our goal here? Well, some of it is to prevent infection. Some of it could be to prevent hospitalization or to improve quality of life, decrease the amount of pain the patient is living with. So, due to severe underlying debility or other factors, the goal of wound care may just be to prevent progression of the wound. So, by minimizing the risk of infection or further progression of the wound, managing multiple issues that cause patient and family suffering, and optimizing the patient's function and quality of life. And here is the CMS regulation for that. So when we're documenting in TrueRCM, there is under your HPI, there is two snippets that have just been added. One is a wound and one is a wound, comma, new. So you can use either one, whether it's a new wound, you would use this one. And in capital letters, I'm saying adjust this snippet in multiple areas. So we know that snippets are adjustable, editable, and need to be customized for every patient. And so usually it's a couple of words here and there. These ones are really significant because we're talking about not only the location of the wound, we're talking about the healing of the wound, the peri wound, the pain. And so much of this snippet needs to be edited. So if you choose to use any of these snippets, they have to be edited. Same thing under assessment. There are two new snippets under assessment. They're under the W's. So wound existing and wound new. And what we're going to do with that is make sure we identify the ICD-10 codes. So if it's a new wound and we don't know the stage, you can put wound to sacrum or pressure wound to sacrum, and then not wound otherwise not diagnosed or existing. So with your ICD-10, so it's staged was the word I was looking for. So wound not staged. So those are the new snippets that are in there under HPI and assessment. So if I move this note over here, this is just a demo patient, and I've literally just copied the snippet. It's easier to see here than those thin lines. But this snippet for HPI is the patient has a new wound too, and I didn't give you a whole long line so that you'd have to delete it. You're just going to write wherever the wound is located at, and then delete that little line right there. And then the wound is open with, and then here's your whole choice. Delete everything. Serous, sanguinous, serosanguinous, purulent, or no drainage noted. Everything but one should be deleted. You should have one answer and everything else deleted. The peri wound is intact, noted with redness, erythema, maceration, calloused, induration noted. It could be as simple as peri wound is intact, period. If everything else is not applicable, delete it. Then the patient reports complaints of pain. Well, we're going to use a 1 to 10 scale or a 0 to 10 scale. So what is their complaints of pain? And then describe the pain. Well, we've given you burning, sharp, throbbing, aching. Do not use all of that. Pick one, maybe pick two, but delete everything that's not applicable. How do you have sharp and throbbing and aching at the same time while you've got burning? So pick one or two, whatever the patient is stating. And then continues on, are they on routine medication? If they're not, delete that. If they're on PRNs, but they can't ask for it, then delete that. They're not able to ask for it based on their cognition. Then a referral to the wound doctor as well as the RD has been initiated. We should do that with every new wound. And a low air loss mattress has been requested. Has it? If it hasn't, delete that out of there, but it should be, unless we're talking about a vascular wound that's on the, or a diabetic wound that's on the foot, then maybe they don't need a low air loss mattress. So delete that out of there. Labs will be obtained, and I'll show you what labs we probably should obtain from that. And then pain management interventions include medications, repositioning, and dressing changes. And then the patient is being followed by the wound team as well as the RD. So we're going to have the wound team and the RD follow this patient. So that's a new wound. If it's a brand new wound, and it'll be under your HPI. This is a patient who already has a wound too, and we don't know where it is, but only like three little lines that you have to delete, and then you can write that in there. Again, you're going to delete everything that is not applicable, and then you're stuck with that statement. Dressing is intact with no drainage noted. Or peri wound is intact with redness. Maybe they don't have maceration, or maybe they have warmth noted. So delete whatever's not applicable. And of course you can add, because these are snippets. So add, adjust, delete. Patient reports complaints of pain, 0 out of 10, 9 out of 10, 8 out of 10. And then how is their pain? How do they describe it? As aching, sharp, throbbing, burning. If you have any other words that you want to use or that the patient used, you can use those as well. And then if they're on routine medications, perfect. If they're not, delete that out of there. And then pain management interventions include medications, obviously, repositioning, dressing changes, and then anything else that makes them feel better. So getting up in the wheelchair 3 times a day, whatever you're going to do to customize this snippet. So under assessment, you've got your wound. Now, what is the assessment of the wound? You're going to put wound to left coccyx or wound to right buttocks. So your wound, your assessment is going to be the location of it. And so this is going to be for a new wound, implement new wound care orders. You can write CMAR, CTAR, you can write alginate, you can write cleanse with normal saline, apply calcium alginate, put border dressing on, whatever you want. It can be simple. You don't have to spell it out, but implement new wound care orders, see treatment record. Then if you requested a new air loss mattress because you said above in the HPI you did, then you're going to leave that there. You're going to put that in the TAR. You're going to write, please order low air loss mattress. And then if you're referring to wound care physician for specialized assessment and management, so you're either going to text via a HIPAA compliant measure, or you're going to let the DON, the ADON know, and then put it in point click care as well. And you can put under the instructions to discharge the order once the wound care physician referral has been made. So easy enough to get rid of that. And then follow up with wound care physician. And we're going to monitor between doctor's visits. So maybe we only have to do that for the first month or two, or maybe only a week or two, and then the wound heals. But we're going to monitor as we need to. Pain management, continue current pain management. If we're going to start them on pain management, let's say we're going to start them on some tramadol, then you can just change this to start pain management with whatever you're going to put into place. A lidoderm patch on the lower back because they have a sacral wound. So you're going to put it on the side or above the wound. Monitor pain levels and adjust medication as necessary. Nutritional status, you're going to consult or refer to registered dietitian for comprehensive nutritional assessment and recommendations. You're going to monitor results of ordered labs. So if this is a new wound and we said it was a new wound right here, we're going to order a CMP and a prealbumin because the CMP is going to give us the total protein and the albumin, and we're going to get a prealbumin because sure enough, the registered dietitian is going to need that, and we're going to need that to put diagnoses in place. Protein calorie malnutrition, adult failure to thrive. Any information that we get from those labs, we should be utilizing so that we can take credit for those diagnoses. And those diagnoses help us justify whether a wound is going to heal or not. And then we're going to adjust the nutritional plan with a dietitian accordingly. And then we're going to educate. Why do we educate? Well, because we get the discussion with the patient that we're doing a discussion as well as collaborating with a patient. Without the patient's buy-in, this wound is never going to heal. So we have to do education to increase fluid or protein intake. So if the patient has dementia, cognitive impairment, you can educate staff on increasing fluid intake. You could even educate patient and staff on increasing fluid intake. So adjust these snippets as needed. And then patient education. So instruct patient or staff on proper positioning to offload pressure from the sacral area. If it's a sacral wound, any other area, we just change the wording. Turning side to side, avoiding prolonged periods with the head of the bed up over 60 to 90 degrees. Well, what if they have a diabetic wound? Well, then you delete this stuff, offload pressure from the foot, left leg, whatever it is. So again, it's a snippet and it needs to be adjusted. Reinforce the importance of communicating pain levels because we need to assess that and they need to respond if they're having pain. If they can't, we need to determine if the patient would benefit from routine Tylenol, routine ibuprofen if they're not at a fall risk, and they don't have kidney issues, whether they need to have something like tramadol, but we're going to evaluate if they cannot communicate for pain, do we need to put something routine in place? And then follow up. Nursing is going to notify the family of the new wound treatment plan and referral to the wound care physician, and then continue to monitor wound healing. That would be our plan. If this is a previous wound, we're going to either continue or change the wound care orders. And you can say CTAR, or you can just, but delete continue or delete change. You don't get to use both. We're not going to continue and change. Low air loss mattress to reduce pressure. If it's again a foot wound, a stasis wound, we don't need a low air loss. They don't have one. Delete that if it's not applicable. Patient is being followed by wound care and then follow up with wound care physician and monitor between visits. Pain management, again, you're going to medicate or continue pain management. Nutritional status, the registered dietitian continues to follow the patient. We're going to continue to encourage fluid and protein intake. Patient education, it could be staff education as well. If we're not talking about sacral, buttocks, and remember, you've got to adjust that. If you're not talking about that, maybe you're not emphasizing offloading pressure from the sacral area, but offloading pressure from the lower extremities, heels, whatever the wound is. And then reinforce the importance of communicating pain levels and then follow up with the progress. So if you have any questions, again, I'm Brandy. My number is down here. My email is bbabin@Mana Health Partners, HP, manahp.com. For anything that you have, please let me know. If you found this helpful, click like. If you didn't find it helpful, send me an email and see what else I needed to add to it. But wishing you good luck as you're documenting, trying to make this easier for you to be including all of the criteria that CMS is requiring us to utilize in our documentation. And I will see you at our next visit. Have a great day.